Welcome to a brief overview of the history of the National Area Health Education Centers program. I'm Michael French, co-director of the AHEC Program Office at A.T. Still University in Kirksville, Missouri. Having been with AHEC since 1990, I've had the privilege of experiencing a significant part of AHEC's history, mostly good, sometimes challenging. In this brief presentation, I'm going to summarize 45 years of AHEC history in around 20 minutes. Not an easy task, but I hope that the content will be useful supplemental information to your experience in the new director's orientation at the biennial National AHEC Organization Conference. As noted on this slide, the presentation includes three basic parts. First, a brief history of the evolution of the AHEC program from its inception in the early 1970s to its current incarnation in 2018. Second, an overview of how the AHEC mission has evolved during that time period. And finally, a summary of the direction in which the National AHEC program is moving today. The history of the AHEC begins with the Carnegie Commission on Higher Education and the Nation's Health. In 1970, the Commission issued a wide-ranging report that in many respects could still be issued today. The excerpt from the Commission's report shown on this slide emphasizes the fact that the progress of the United States in extending life expectancy and preventing infant mortality was not impressive when compared with the experience of many other developed countries, a finding that is reflected in current reports related to these same conditions. The Commission suggested a number of things that it thought could improve the healthcare system in the United States. One of those suggestions was the creation of what the Commission called Area Health Education Centers. The period of time during which the Carnegie Commission carried on its deliberations and issued its report was seminal in the development of a number of initiatives to improve health and the healthcare system in the United States. This was the period of time during which the community health centers, family medicine as a recognized specialty, and the National Health Service Corps all got their start. The Community Health Center Network had its federal genesis in the Economic Opportunity Act of 1964 that first provided support for neighborhood health centers, which have evolved to become the community health centers of today. In the same time period, the specialty of family medicine was emerging. Officially recognized in 1969 as the 20th recognized medical specialty, family medicine had 14 residency programs approved at the end of 1968 and beginning of 1969. In its 1970 report, the Carnegie Commission recommended that 126 area health education centers be established across the country to serve localities that didn't have an academic health science center. The AHECs would be associated with major healthcare delivery systems and would foster cooperation between existing academic health science centers and the community. The Commission also recommended the establishment of a National Health Service Corps. The NHSC was created by Congress under the Emergency Health Personnel Act of 1970 and first received dedicated funding in 1972. As Congress passed the legislation that created the AHEC program, the Comprehensive Health Manpower Training Act of 1971, it viewed AHEC as the third leg of a healthcare improvement stool made up of community health centers, the National Health Service Corps, and AHECs. The first AHEC programs were federally funded in July of 1972. These 11 programs formed the first generation of AHECs. This map from the Carnegie Commission's report shows the locations in which the Commission felt AHECs should be created. You might want to compare the locations suggested by the Commission and those in which we today have AHEC programs and centers. Throughout the history of the AHEC program, the parameters and requirements for federal support have been contained in authorizing legislation passed by Congress. The authorizing legislation has been revised every 5 to 10 years over the history of the program. While the basic mission of the program has remained relatively constant, the legislation has, with each new authorization, added more specificity to the requirements and expectations placed on the program. The last authorization for the AHEC program was enacted in 2010 as part of the Patient Protection and Affordable Care Act, also known as the ACA. This was a 5-year authorization that has since expired. There are currently ongoing discussions in Congress aiming toward reauthorization of the federal AHEC program and other training grant programs included in Title VII of the Public Health Service Act. As the various reauthorizations have occurred, one important theme has been an increasing emphasis on academic community partnerships as a defining characteristic of AHEC programs. Almost from the beginning, the structure of an AHEC program has required the presence of a university-based program office and at least one community-based regional AHEC to constitute an AHEC program. An AHEC program cannot exist unless it is a collaboration between an academic health center and one or more regional area health education centers. Over time, the expectation that AHEC programs will be models of collaboration between university-based AHEC program offices and community-based regional AHECs continues to increase. This slide graphically represents the model for the organizational structure of AHEC programs that has evolved over the years. The left side of the graphic illustrates the expectation that an AHEC program should be a federal, state, and local partnership, with each partner providing resources and playing a significant role in the implementation of the program. The right side of the graphic illustrates the collaboration between the university and communities, between the program office and regional centers, with a common mission encompassing individual priorities of the partners. In its ideal envisioned form, the AHEC program will engage the resources of the academic health center to support development of the community's health workforce and healthcare delivery system, and will engage the resources of the community to support the educational mission of the academic health center. A rough shorthand description of the history of the AHEC program at the federal level assigns the various AHEC programs to a series of generations reflecting the evolution of the program across the years. In a certain sense, various generations can be described as siblings, but are not identical to one another. The generations roughly correspond to the congressional authorizations under which they were initiated. The 11 first-generation AHECs were first funded in 1972 and developed over the next 10 years. While a significant number of these programs did not continue beyond the first or second funding cycle, some did and today continue providing AHEC services. For example, the North and South Carolina AHEC programs. First-generation programs were frequently linked with newly emerging family medicine residency programs, a linkage that provided and still provides some stability of financial resource for these programs. The second generation of AHEC programs emerged in the period 1978 to 1988, when 12 additional programs were provided initial federal funding. These programs were in new geographic areas, such as Colorado and Connecticut, and due to the evolution of the federal AHEC authorizing legislation, had an increased focus on engagement and collaboration with communities outside the academic health center. New authorizing legislation provided increasingly specific guidelines based to a great extent on lessons learned from successful first-generation programs. Third-generation AHEC programs were the largest in number, 17 additional programs receiving initial federal funding between 1985 and 1995. My own AHEC program in Missouri was one of these third-generation programs. These programs, both the university-based program offices and regional centers, tend to be smaller in size due to both reduced federal funding and less direct connection to family medicine and other residencies and the income generated by those residencies, which provided significant support to many first and second generation AHECs. This generation continued to see an increase in the expectation that communities and regional AHECs should play a significant role in establishing the direction for an AHEC program. While the inclusion of third-generation programs built a structure throughout the country, and a significant portion of the United States was covered by AHECs, the fourth and fifth generation AHECs, which emerged after 1995, were primarily used to fill gaps in the geographic and population coverage in an attempt to assure that AHEC served as many of the states and territories of the United States as possible. This generation also includes new AHEC programs that replaced some previous generation programs that had exited from the federal AHEC network. These generations also experienced some loss of AHEC programs as they were building that have not yet been replaced. The current AHEC authorizing legislation contains a sense of Congress statement that every state should have an AHEC program in place, a goal that has not yet been achieved. The evolution of AHECs over the years has seen a number of shifts in structure and emphasis, including a shift from more centralized models based in the academic health center to more decentralized models including substantial roles and influence for regional AHECs, a shift from emphasis on centralized residency programs to more emphasis on community-based training programs, a shift from larger programs with significant financial support to smaller programs that sometimes struggle for resources, a shift from federal guidelines that allowed significant flexibility in how the AHEC programs would be implemented to more structured guidelines that focus on achieving specific outcomes, and a shift from programs that were primarily supported with federal resources to programs whose state and local support frequently outweighs support from the federal AHEC program. Currently, there are 49 AHEC programs that receive partial federal funding and one AHEC program that is state-supported without federal AHEC funding. University AHEC program offices are based in 44 states, the District of Columbia, and Guam. A few states have multiple university-based program offices. There are approximately 269 regional AHECs that comprise the community base for AHEC programs. Not all are federally funded, and some exist in states that do not have a program office within their borders. There are centers in 45 states, the District of Columbia, and the Pacific Basin. This slide shows the location of AHEC programs in the contiguous 48 states. Due to the size of the map, the AHEC programs in Alaska, Hawaii, and the Pacific Basin, and Guam are not displayed. Since the beginning, AHEC programs have focused on developing the primary care workforce, decentralizing medical and dental education, reducing maldistribution of healthcare providers, and fostering academic center engagement in communities. As AHECs and the federal AHEC program evolved, the scope of programs grew to include a focus on program elements that were not emphasized during early AHEC history. This included focus on health career pipeline development, expansion to more professions, and then to interprofessional education and practice, increasing attention to the diversity of the healthcare workforce, and encouraging partnerships and collaboration between the academic health centers and communities. In the recommendations of the Carnegie Commission, AHECs were envisioned to focus on improving direct patient care, increasing availability of graduate medical education, supporting clinical rotations for medical, dental, and allied health students, and providing continuing professional education programs. They would be based in healthcare delivery systems and structured similar to outreach arms of academic health centers. As the federal AHEC program evolved after the first 10 years, the mission articulated at the federal level also evolved, as described on the bottom of this and the following slide. Take a moment to read the mission description that has guided AHECs for most of the past 30-plus years. In 2017, the Federal Health Resources and Services Administration, or HRSA, restated the mission of the AHEC program within the federal support structure, adding a focus on developing and enhancing education and training networks in multiple venues, as well as on practice transformation. The focus on fostering increased supply, diversity, and distribution of healthcare workforce and modeling academic community partnerships continued. This mission restatement was accompanied by some new and different expectations for federally supported AHEC programs. One significant driver for these changing expectations was the recognized variability in activities and outcomes from AHEC program to AHEC program and among their constituent centers. This variability was perceived to result in a lack of a nationally recognizable AHEC brand and difficulty in making a strong case for AHEC support at the federal and sometimes at the state level. The statement that if you've seen one AHEC, you've seen one AHEC no longer made sense, if it ever had, to those who provided and administered funding and support for AHEC programs. A second driver seen as militating for change included the perception that AHEC activities to some extent duplicated or overlapped with other HRSA and non-HRSA programs, and that AHECs could be strengthened by building strategic partnerships rather than pursuing separate activities in some traditional AHEC focus areas. A third such driver was the perceived need for developing clearer and more robust performance measures for AHEC programs. A fourth and final driver was a desire to more closely align AHEC programming with HRSA priorities for increasing workforce diversity and distribution and supporting practice transformation. An expectation that federal support would be focused on activities impacting individuals already in health professions training programs was a significant change in priority that grew from these drivers. The other priority expectations that grew from these drivers are detailed on this slide and the next. They are expectations with which you are likely very familiar. AHEC scholars, community-based experiential training, which is team-based and focused on service to rural and underserved areas, infusion of specific core topics into AHEC programming, and limited federal funding support for AHEC youth pipeline and continued professional education activities. The reordering of AHEC programming priorities has also been coupled with a priority for enhancing strategic partnerships that strengthen AHEC high-priority activities and provide alternative ways to support AHEC activities that face limitations of federal support, such as youth pipeline and continuing professional education. Ongoing evaluation of AHEC outcomes and quality improvement of AHEC activities remains a high priority, including an expectation that every state that has one or more AHEC program offices should have a statewide evaluation plan that engages all AHEC entities in the state. So, after a whirlwind tour and summary of the past 45 years of AHEC, we arrive at the next mountain to scale, 2018 and beyond. I, for one, am confident that with a 45-year history of success to build on, the best is yet to come. Thanks for being part of the AHEC journey. If you have questions or comments, here's my contact information. Thanks again.